is also expelled out. अरे इसकी bleeding तो stop ही नहीं हो रही है. Intern, please come here and check the vitals. I think she is going into primary PPH. Let's call for help. Call for help. Call for help.
Hello, Dr. Phulo. Please come to the emergency.
Dr. Phulo, my patient multi-capita, 35 years old. I think she is going into primary PPH. We have already used 5 to 6 bottles, which is completely soaked with blood. The liver and the antenatal period was not complicated. Possibly due down.
So this is a case of true postpartum hemorrhage, and this is the golden first hour of PPH management. So we need to start resuscitation as soon as possible. Please secure the IV line, monitor and manage every bleeding in circulation, administer crystalloids, and insert Foley's catheter. Interns, please send blood for cross-matching tests and coagulation profile and check the vitals every 15 minutes and inform me.
2 large for highly cannula has been inserted. And 1,000 ml nucleic acid given out of 20 minutes. And folic catheter is injected. And urine will be collected. And there is no humidity value.
Interns, what are the vitals?
Airway is patent. Respiratory rate is 20 per minute. Blood pressure is 110/80 mmHg. Pulse is 128 per minute.
Okay, please go and inform the attendant about the situation and ask him to arrange for 2 units of blood. We may need that in future.
Yes, doctor.
अरे डॉक्टर साहब माँ और बच्चे कैसे हैं?
आप निश्चित रहिए, माँ और बच्चे दोनों करते हैं, लेकिन कभी कभी क्या होता है डिलीवरी के बाद पूरी ज़्यादा हो जाता है, इसके लिए आपको 2 यूनिट O पॉजिटिव ब्लड जल्दी रहना चाहिए.
अरे ठीक है डॉक्टर साहब, मैं कुछ करता हूँ.
Okay, the first step for PPH management. The first step of PPH management is to check the uterine tone. In this case, the uterus on palpation is felt soft and flabby, so it is highly likely a case of atonic postpartum hemorrhage.
Okay, Dr. Let's rule out the other causes.
Okay, so please go and inspect the placenta while I am performing the birth technical examination.
As we see, placenta is completely delivered and all the membrane is intact.
After performing the birth technical examination, there is no evidence of trauma or tear, so it is unlikely to be a case of traumatic PPH. Interns, what about the blood reports and the coagulation profile?
Doctor, there is no history of bleeding disorder. Coagulation profile is normal, but hemoglobin is 7 after testing.
What about the vitals?
Doctor, blood pressure is 100/76 mmHg and pulse is 128 beat per minute.
So the next step is to perform the continuous uterine massage and also administer the bulk gram of tranexaminase acid in normal saline. And we also have to start the administration of oxytocin drugs, starting first with oxytocin.
Units of oxytocin has been injected in 500 ml of NS. And as there is no any renal insufficiency and hematuria, we have to give 1 gram prenexor over 100 ml of NS over 20 minutes.
The patient is still bleeding and the vitals are also deteriorating, so we need to go for another oxytocin drug. So please inject methogen after checking the contraindications.
In turn, go and ask the attendant about the contraindication of methogen and also ask for asthma for power.
और डॉक्टर साहब,
क्या आपके वाइफ को पहले कभी इसकी समस्या रही?
नहीं बिल्कुल नहीं.
टीबी बनने की समस्या?
नहीं डॉक्टर साहब बिल्कुल नहीं.
जहाँ खांसी या फिर सांस फूलने जैसी समस्या कभी पहले नहीं?
नहीं डॉक्टर साहब, वो तो एकदम सेहतमंद थी.
ठीक है.
carbotrost. Please give the carbotrost. You can repeat it every 15 minutes to a maximum of 8 doses.
0.2 milligram of carbotrost has been injected IM.
Then please also give a tablet of misoprostol of 800 micrograms sublingually.
Doctor, why we cannot give a vaginally?
See, this is a case of PPH, so much of bleeding is happening, so you can wash away the blood. So that is why we are going to sublingual route.
शांति अपना मुंह खोलो. Now all the oxytocins have been administered. 30 minutes have been passed, and we have done continuous monitoring of the patient.
The condition of the patient is not improving, so we need to perform bimanual uterine compression.
Bimanual uterine compression is performed. After separating the labia majora, the whole hand is inserted into the vagina in a thin-step vessel, such that the back of the hand is directed posteriorly and the knuckles is towards the anterior fornix, and the other hand is placed behind the over the abdomen behind the uterus, such that the uterus is anteverted and the uterus is squeezed in between the two hands so that the bleeding will be stopped.
The bleeding is not stopping, but the vitals.
Blood pressure is 88 by 64 mmHg and pulse is 140 mmHg.
So we need to perform uterine tamponade. Please avoid gauze packing, it's obsolete, it has very less benefits. Proceed with balloon tamponade.
This is one of the example of balloon tamponade. This is condom catheter. One end is fitted with condom and it is inserted inside the uterus and filled with 300 to 500 ml of normal saline. Inside uterus it compresses to stop bleeding.
Condom catheter has been inserted.
Other examples of uterine tamponades are bubbly balloon catheter, condom catheter, second leg mode esophageal catheter, and uterine tamponade.
The condition of the patient is still not improving and she is still bleeding, so we need to shift her to OT. While shifting to OT, please employ temporary measures, either compression of abdominal aorta and apply non-pneumatic anti-shock garment. And please make a call to anesthesia.
Hello, anesthesia department. I'm calling from labor room. We need an urgent OT. Our patient is suffering from postpartum hemorrhage.
Compression of abdominal aorta is performing and simultaneously the femoral pulse is also checked.
Now the patient has been transferred to OT, which was already prepared by senior anesthetists. Blood products have been arranged and everything is ready for the patient.
We need to perform the surgical methods, first starting with uterine compression sutures.
Surgical method include compression suture. The first one include V-link suture. The long abdominal suture is passed over and through the uterine wall in a brace-like pattern to firmly compress the anterior and posterior uterine wall. Second method is Haven suture, also called modified V-link suture. In this modification of V-link suture technique, vertical suture is applied without needing the requirement of hysterectomy. Third one is choose square suture. Choose square suture is multiple square compression suture applied all over the anterior posterior uterine wall. They are directly opposing each other so that bleeding can be compressed.
Even after performing the uterine compression suture, the condition of the patient is not improving. So we need to proceed with stepwise uterine devascularization.
In stepwise devascularization, ascending branch of uterine artery is dilated at the lateral border between upper and lower uterine segment. As we know that uterine artery runs at 3 to 9 o'clock position. The suture is passed in the myometrium 2 cm medial to the uterine artery. If it fails, then we
What should we do now, doctor?
So after performing the stepwise uterine devascularization, the bleeding is not stopping. Now our last resort is a subtotal hysterectomy.
Subtotal hysterectomy, also known as supracervical hysterectomy. The rule is clamp, cut, and draw. It is removal of the body or corpus of the uterus and leaving behind the cervix. It is often preferred over total hysterectomy because it is faster, easier to perform, and carries a lower risk of greater or late age.
So we have finally saved our patient. But it is rightly said that prevention is always better than the cure. So what are the preventions of postpartum hemorrhage?
High-risk patients such as twins, hydrangeas, multiparity, and previous history of PPH should be screened and delivered in a well-equipped hospital.
Observation for almost 2 hours after delivery to make sure the uterus is hard and contracted before sending them to the body.
Examination of the placenta and membrane should be the routine to detect at the earliest indicated part.
Blood grouping should already be done by all women. It saves time in emergency.
Active management of third stage of labor should be routine in all women undergoing delivery. It reduces the PPH by 60%.
Placenta localization must be done in all women with previous C-section to prevent placenta ectoderm or pearl